All right, it's shortly after 12, so let's get started. We've got a great set of talks for you this afternoon. Hello, and thank you for joining us for part 2 of Health Promotion Ontario and Ontario Public Health Association's 4-part webinar series. The topic of today's webinar is the shadow pandemic. My name is Bethany Jennings, and I'm a volunteer on Health Promotion Ontario's Professional Development Committee, and I will be facilitating today's webinar. I'm joined today by our planning committee that has developed a series of webinars in replacement of our annual Health Promotion Ontario conference. In collaboration with the Ontario Public Health Association, we have put together a set of timely webinars every Thursday during the month of November. Our focus for this series is to highlight health promotion from a variety of different sectors during the global pandemic. While of course we would have rather met in person, we're thankful that we can join for, even though it's an online format. Today's webinar includes 3 panelists that will focus on the topic of the shadow pandemic, also known as hidden harms. While the emphasis in recent months has been on the very real threat of COVID-19, mental health and gender-based violence are steadily increasing amid the pandemic. These rising health issues are sometimes overlooked consequences of the pandemic and deserve attention. This webinar will highlight the importance of maintaining population health promotion interventions in combination with other public health services. Before we begin the webinar, I'm going to briefly talk about Health Promotion Ontario. We know that we have some HPO members joining us, as well as non-members joining us today, and we'd like to take this opportunity to explain what Health Promotion Ontario is for those of you that may be less familiar. Health Promotion Ontario is the voice for those who are in the profession of health promotion across Ontario. We seek to advance the critical importance of health promotion and its practice through professional development, membership, communication, and advocacy. Health Promotion Ontario has been a constituent society of the Ontario Public Health Association. We've been active since 1987. Health Promotion Ontario is a multidisciplinary group of dedicated professionals that represent a variety of organizations, such as public health units, community health centers, universities, and other health-oriented organizations. We are the founding chapter of Health Promotion Canada, and we align with its vision, mission, and values. On that note, we'd like to ask that you complete this poll just so we get a sense of how many members we have joining us today. So, the poll should be launched, and you should see it on your screen. Great. Give you about 30 more seconds. And just to keep in mind, with all of that being said, if you're interested in becoming a member, one of my colleagues has placed the link in the chat that can tell you more about that process. So we'll give you 10 more seconds. All right. Thanks everyone for participating in that. Now, before I hand off the stage to our presenters, I'll briefly go over the agenda for today. Each presentation will be 10 minutes, and once all the presenters have spoken, we'll open up for a full panel discussion. In the webinar mode, as an attendee, you'll notice that your microphone and video are automatically turned off, and this will help us to avoid any interruptions. You can submit typed questions using the Q&A feature found in the middle of the Zoom action panel, which is probably at the bottom of your screen. Please feel free to ask your questions at any point during the webinar, and we'll address them at the end during the discussion period. We'll do our best to incorporate all of your questions, at least as many as we can. All right, I'd like to begin today's webinar by introducing our first panelist, Professor Vivek Goel. Dr. Goel obtained his medical degree from McGill University and completed postgraduate medical training in community medicine at the University of Toronto. His research has focused on health services evaluation and the promotion of the use of research evidence in health decision-making. He was the founding scientist at ICES and the founding president and CEO at Public Health Ontario. Vivek has held a number of senior administrative roles at U of T. He stepped down as VP of Research on June 30th to focus on COVID-related work. He is currently a member of the COVID-19 Immunity Task Force and the scientific advisor for CanCOVID, which is the national research platform for COVID-19 research. Today, Dr. Goel will be sharing the impact of COVID-19 on health behaviors, for example, immunization, physical activity, drug and alcohol use, and nutrition. And whenever you're ready, you can begin sharing your screen.
Okay, thanks. So thanks for the kind introduction, and it's a pleasure to be here today. And I'll just start by showing this is from an article I wrote back in the spring on what I feel continues to be the undervalued role that public health plays. And another way of thinking about it, which I think was mentioned in the introduction, is that our response to COVID-19 continues to be very medically driven and very much focused on disease cases of COVID. And if there is an overarching strategy, it appears to be protect the healthcare system and the in terms of what many of the leading voices seem to push for, and the voices from a public health perspective are dampened. And this image, which I didn't select, the editors of the conversation put up, but I think speaks to it. Everyone in the United States, I think, recognizes Anthony Fauci. I've asked how many people recognize this individual, and even in public health audiences, he's not a very visible figure. This is Robert Redfield, the head of the Centers for Disease Control. And to me, this picture really speaks to the medicalization that the infectious disease specialist, the head of the National Institute of Immunity and Infection, has been driving the response more visibly than the head of the Centers for Disease Control. And what that means is that as decisions are being made, broader population health consequences do not seem to be valued as much as the consequences from a medical perspective. I've listed a number here. Some of the other panelists will be talking about some of these points. And so I'm going to focus in on some of the data that's starting to emerge around impact on preventive behaviors, as well as some of the equity impacts that we're seeing. So this is from, there's a lot of information on this slide. This is from a report that CIHI just put out a couple of weeks ago in terms of impact on health systems. But I want to take a look at this data from a sort of a population health perspective. So one very positive thing is we had a shift to 52% of the consultations happening through virtual care. This is something that has been difficult to implement in the healthcare system for some time, but happened very rapidly, as has the shift to online teaching and a number of other things. We had fewer home care screening assessments being done, which has an impact on people being able to stay in the community longer. We had a decline in visits to emergency departments across all categories of acuity, which suggests that people were afraid to go into the health system. And we had a decline in visits to medical physicians, family physicians, as well as medical specialists, and a very dramatic decline, much larger, in surgical specialists because surgeries were being canceled. But what that means from a prevention perspective is we're now starting to see, as was reported a few weeks ago, people presenting with more advanced cancers, or people simply not presenting with cancers at all. The head of radiation oncology at Princess Margaret was quoted in this article as noting that there are fewer people presenting, which means that their cancers are progressing likely to a more advanced stage before they're going to be detected. And in terms of children, this paper in the CMAJ highlighted the number of missed immunization visits that have taken place because of those in-person visits to family physicians and other healthcare settings not happening. This report from Ryerson in the summer looked at changes in children and youth in physical activity. And so about a 56.8% decrease in physical activity, more screen time, 84.1% increase in screen time, decrease in sleep duration, not as significant, but decrease in sleep quality being reported, quite significant. Of interest, and they've got a number of other data points in this report, but I picked out this one, that there was a greater decline in physical activity in Black, Indigenous, and people of color. And we know that many of the other impacts have disproportionately affected different communities. This is from a global report on the impact on children missing out on school nutrition programs. And you can see Canada is not unaffected by this. And I use this as really a proxy for, there's so many other impacts. In Canada, we have data on increased use of food banks in many regions of the country, increased because of the people not going out as frequently to get their food, less fresh food. The very consistent data on more alcohol and drug consumption, and we've seen quite a bit of data on increased mortality from opioids during the lockdown or shutdown periods. And very significant impacts on mental health being reported through a variety of sources. And again, CAMH had a report out last month showing the difference by gender and different groups. I've done some work with Laura Rosella, who's also at the Delavan School of Public Health, and an economist, Kevin Bryan at Rotman School, to estimate what the impact from the unemployment is on health utilization as well as mortality. And what I just emphasize here is from this model is from the spring shutdown effects. So through March through June, the unemployment, Laura's got her models that estimate premature deaths that would take place. And you can see that about 4,000 premature deaths as a result of the spring shutdowns. We know that there are many people that remain unemployed, and now with the second wave lockdowns, these numbers will continue to increase. So this is perhaps a hidden part of the pandemic that's not talked about as much. Just to close off, the younger generation is going to have very significant impact. We know the impact on children in terms of early childhood development. Students in university are not getting the experiences that they would normally have, even with the best efforts with the move to virtual education. We know that a lot of that experience is actually the social aspects. And there are estimates that for lifetime earnings for this cohort will be in excess of $25,000 per year. And that again was done in the summer. As things continue to extend, it's going to likely get worse. So these are not insignificant consequences from the consequences of the public health measures. And the final point I just want to highlight about the public health measures is that they have been implemented in ways that have been found to be very inequitable. And in this report from the Canadian Civil Liberties Association back in June, they showed that in many regions of the country, Black people, visible minorities, were more likely to get tickets for violating some of the public health measures, whereas education and warnings were more likely to be used in white populations. And so just as we're thinking about the implementation of public health measures, we always have to think about their consequences as well as their disproportionate impact on different communities. Look forward to the discussion.
Great, thanks Vivek for a great talk. Just going to my screen. All right, our next speaker is Giovanna Good. Giovanna is the Chief Nursing Officer and Professional Practice Leader at Lambton Public Health. She is also the co-president of the Western MPH Alumni Association. Giovanna works towards enhancing effective public health practice of various disciplines. Throughout her work, she focuses on building capacity for upstream, equity-oriented population health approaches at the individual, organizational, and systems level. Since the pandemic began, she has actively supported the COVID-19 response in her local community. Giovanna will provide a local public health perspective when discussing the balance between emergency response and upstream population health interventions. And whenever you're ready, Giovanna, you can begin sharing your screen.
Hi, everybody. Thank you. I really wanted to just say thank you to the organizers for inviting me to speak today and to share my perspectives. I'll be honest, when I was first asked to do this presentation, it was summertime and only a few months into the pandemic, and I was still fresh and excited to contribute. And fast forward a few months and I found myself having to carve out bits and pieces of time to pull this together in time for today's webinar. So I'm glad Vivek was able to show lots of data. Today I'm going to really be focusing on the local public health perspective and really more reflections of the pandemic response to date. So obviously, you know, as of 3 p.m. yesterday, this was the worldwide total. That's a huge amount of cases. But this is just numbers. They're just that. The amount of work actually involved in COVID response cannot be defined alone by the number of cases. And, you know, as Vivek clearly shared at the outset of his presentation, the work of public health has really largely gone undervalued. We are very tired. And in reflecting with our local medical officer of health about, you know, providing this presentation, he's like, you know, we're tired. And so I thought, you know what, I have to share that because it's been a very demanding pandemic, a long, intense, you know, 8 months so far. We're sharing this opportunity with the rest of the world. But I do find myself truly fortunate to have this opportunity as it forced me to reflect on the response to date and think about the future, something very few of us working on the ground in public health units maybe have likely had any time for. So today I'm going to focus on acknowledging the successes we've had in the context of the capacity we've had, reflecting on our response to date, and sharing insights for the future and finding a better balance with upstream approaches in emergency response. So acknowledging success. Some of the organizational capacity literature states that focusing on performance alone, so, you know, number of cases prevented, causes us to ignore other important elements of capacity that contribute to success, and in this case, a successful COVID response. So if we reframe success by asking how well are we doing given what we have to work with, it's a lot easier to be able to come up with lots of things that we should be proud of at the local public health level. I know that each public health unit likely has their own successes to share, and today I'm going to just share some examples from my own public health unit, Lambton Public Health. And as a small public health unit with a very high case rate at the outset of the pandemic, the majority of our capacity was dedicated to managing and mitigating the spread of this virus. Every single staff member had a purpose and a role in COVID response, regardless of their discipline. They effectively rose to the challenge, handled constant change, daily, sometimes hourly change. We managed uncertainty and quickly became experts in our roles. And we truly have so much to be proud of. We also were able to quickly mobilize dedicated teams focused on developing guidance for specific settings and population groups who tend to be living in more vulnerable circumstances. So these settings or groups that we focused on were, you know, community supports, vulnerable populations, healthcare providers, families and caregivers, workplaces, and municipalities. We had health equity champions supporting these teams with a focus on identifying additional supports for individuals at poor risk of health from COVID-19. And within each team, they focused on developing policies and protocols for each setting that were equitable and practical, which was extremely important. We encourage workplaces, for example, to develop policies that would support employees of school-age children in the event they require time off to care for a sick child or an isolating child. Another thing we're proud of is that we've engaged with and built capacity of community partners that service populations most impacted by health inequities. So some examples here, we work very closely with social services to open an isolation center for homeless and underhoused populations to access. We also partnered with our local emergency medical services and social services to create a mobile outreach team consisting of a public health nurse, community paramedic, and social worker who would visit individuals in shelters and isolation centers and offer a variety of supports from COVID testing to health assessments, referrals to social services. And we also provided staff within those settings some training and capacity building, especially related to infection prevention and control, as that is not an area they typically are familiar with. We also were kind of a voice to local decision makers on the most recent evidence. One example is that our medical officer of health put together an evidence brief on the equity considerations of mandatory mask use prior to implementing any bylaws. And finally, we developed a Lambton Strong campaign, primarily through social media, with the aim of recognizing the kindness and compassion others have shown in our community during the course of the pandemic. And we also shared messaging on our social media platforms that fostered a sense of community connectedness, understanding, and support. I welcome others who are on the line from other public health units to sort of think about their successes as well in the context of the capacity they've had. In reflecting on the response to date, I have three major reflections that I'd like to share today. So number one, risk behavior is not just an individual phenomenon, it is socially structured. This is an important thing when reflecting on what I was going to say to everybody with our medical officer of health. He really did explain that we need to remember that risk behavior is socially structured. Social structures fashion risk in individuals' lives and how individuals act in response. We really shouldn't treat COVID any differently. When we think of diseases like HIV, social risk behavior is typically viewed as the most important determinant of disease outcome. And COVID-19 shouldn't be any different. We really do need to shift our conversation around risk, and reflecting on social action theories are great places to start. They aim to understand the interplay of social factors which give rise to people's individual risk perceptions and actions. And looking to these theories, we can look for better ways to engage with communities to understand which public health interventions will create conditions where risk reduction for COVID-19 actually becomes realistic, feasible, and possible. So shifting our conversation, as Vivek also mentioned, we've primarily had a biomedical approach to this COVID-19 pandemic response, where the focus has been on reducing people's physiological risk factors, and we've used interventions like screening and testing. We need to, we've also focused on a behavioral approach, so reducing people's behavioral risk factors by asking them to, wash their hands, wear masks, do physical distancing. What we need to move towards, and what we also often value in health promotion, is moving to that socio-environmental approach where we're trying to reduce people's psychosocial risk factors. And the interventions that anyone who's ever worked in public health and health promotion are familiar with is right from the Ottawa Charter, public and promoting public policies related to social equity. So, creating supportive environments, strengthening community action, developing healthy public policy, developing personal skills, and reorienting health systems. So much work in these areas can be done in the future to ensure a more balanced approach to the pandemic response. My second major reflection is that we've lost an important voice, due to the demands of the COVID response. So public health is one of the few organizations in the health system that has a mandate specifically in communicable disease control. The consequence of this is that when the demand work of COVID response prevails, all hands have to be on deck and an important voice gets lost. That voice is the one heard at all levels of decision-making as the enablers, advocators, connectors, and mediators of policy interventions that impact poverty, homelessness, and how resources are distributed in society. And so it's important to keep in mind that there has to be a way to find a way to push that voice forward. And maybe that has been done in other areas. My experience is it's just not been an opportunity The third major reflection I have is that our challenges in addressing health inequities haven't changed. They're just more intense and visible. In 2017, I did develop a report based on a literature review that outlined the main reasons why equity action in public health has been limited. And so on a good day, public health struggled with those challenges, but with even less capacity during this pandemic, it'll be a continued struggle. So the challenges that research I had done outlined, I'm just adapting it here in the context of COVID response when I was reflecting. So a useful analogy at the systems level is that, if a home represents society, the pandemic forced the walls of the home to crumble. Things like job loss and mental illness is what we saw, but it was due to an already insecure foundation, which the foundation being structurally determined issues like income distribution and racism. All the same issues we had before the pandemic are still there, they're just more intense and visible. And then at the community level, how engaged and aware are decision makers and community members about health equity issues? This is something public health has worked on for years and we've tried to accomplish. And one's values and ideology will influence their support for or against program services and healthy public policies that reduce health inequities. And so in an individualistic society where people view health as an individual responsibility, it's very difficult to sort of move towards interventions that encourage people to sort of look out for each other. At the organizational level in public health, complex problems have always traditionally required complex solutions, and we require intersectoral action to get to those solutions. And this takes an extreme amount of time, coordination, and sharing, and a long-term commitment to a common vision. This is difficult to achieve without strong leadership. And so in a time where we are constrained, it's very difficult to be that backbone institution leading, coordinated responses. And also, another challenge is that knowledge is always produced by practitioners like myself working at the local level in a service delivery context where publishing or report writing is not always a priority. And so it's difficult to identify best practices or evidence that will, allow us to make an impact. While we do produce a lot of great literature, sometimes that's hard to search for and access. And then at the individual level of the public health system, there's a continued need to build capacity in the public health sector and understand health equity and the social determinants of health. And achieve congruence with those concepts with individual, organizational, and societal values. We're just probably not there yet. So moving on to my insights for the future. I hope I'm doing okay for time. I'll just make sure in the chat here. Okay. So how can we find more balance and what would an upstream pandemic response look like? These are just my preliminary thoughts so far, and definitely nothing that is true per se, but my experience. And one element of an upstream response is focused on leadership and commitment. So leaders at all levels of the health system must identify champions and protect time for them to plan for and implement health promotion strategies focused on that socio-environmental approach. Informal systems are also important, right? So, the way we interact with our own colleagues, our peers, the way we interact with community, contextual and cultural influences are going to determine how successful upstream interventions that we do try to put forward would be received. It's important that we work to foster a sense of collective versus individual responsibility for health by emphasizing the social construction of risk for COVID-19. As mentioned, there are countries who are faring a little bit better with COVID response, and they tend to have that prevailing view of health being a collective responsibility. Places like Denmark have seen much greater success than us. And if we can target the social determinants of risk behavior, the idea is that we will have much more success changing behavior for COVID-19. Another element would be our formal systems. So in Ontario, I'll speak specifically to that. Our Ontario Public Health Standards sort of set out our mandate. Health equity is a foundational standard within our mandate. So we really need to try to shift the balance, prioritize work with communities to build on their strengths, increase their control over the factors that define their health. So we need to get back into the opportunities of conducting, needs assessments, setting priorities, doing joint planning and capacity building, and strengthening our local partnerships, especially at a time where our capacity is reduced. Our partnerships become more important than ever. And we need to be, probably is a good time to start that shift from providing education and access to information to interventions that create healthy settings. And then resources. So the application of health promotion principles and methods to tackle infectious diseases have been largely neglected. And this is traditional, right? In public health, typically health promotion focuses on more the non-communicable disease pieces. So we need to leverage health promotion expertise that we have in the field to increase the knowledge and skill of professionals who work in communicable diseases to adopt health promotion approaches. And one of the researchers that I found for this, I have my references at the end of this presentation, basically said that we could be focusing more on intervention research versus the traditional approach we take in public and health promotion, which is on causality or outcomes. And finally, we need to seek to understand not only how viruses spread, but the ways in which people make decisions, organizations operate, and how communities relate and react in relation to them. And finally, the final element of an upstream response would involve fostering good partnerships or governance and decision-making. So health, or the threat of ill health, has obviously become the prevailing concern these days with COVID-19. It has taken precedence over many other issues, but this isn't quite our vision of health in all policies, right? So the coordination of key messaging and alignment of goals between the health sector and other sectors and partners is going to be necessary to help us respond to pandemics in the future. We can't do this alone, and we need to be coordinated not just with the health sector, but with education and things like that. And there are great successes that have happened so far, but there's more work that can be done. And it'll be critical to focus on the recommendation of feasible solutions that are within the decision maker's capacity to act. So these are just my initial reflections and thoughts. I look forward to hearing from everyone else, and thank you again for this opportunity.
Great, thanks Giovanna for a great look at some next steps and upstream approaches that we can talk about during the discussion period. Our next speaker is Dr. AnnaLise Trudell. Dr. Trudell is a gender equity consultant and manager of education, training, and research at Anova. Anova is the Women's Shelter and Sexual Assault Center in London, Ontario. She brings extensive analysis of the causes and impacts of gender-based violence and the prevention programming through her doctoral and postdoctoral research at Western University. As manager at Anova, she has overseen the facilitation, curriculum development, and evaluation of youth anti-violence programming and professional training. She is a seasoned public educator and facilitator with over 500 lectures and presentations engaging youth, professionals, and post-secondary students throughout public education. Dr. Trudell will review and help us understand the impacts of COVID-19 on gender-based violence services and survivors in Canada. And whenever you're ready, AnnaLise, you can share your screen.
So I'm going to talk about the impact of COVID on gender-based violence today. I'm speaking on behalf of Anova, but this work was also done in partnership with Ending Violence Association of Canada. They're an umbrella organization of gender-based violence organizations across the country. So when COVID hit us in March, a lot of us were sort of really, it almost felt very foreshadowing that we would see a drastic increase in gender-based violence, be that domestic violence or sexual violence. And partly that was based on some of the data that we already had. For example, there was over a decade of coroner inquest reports that have very clear red flags that are present prior to a domestic homicide. And many of those were present in the sense of social distancing leads to isolation of the victim, which is one of the red flags. Job loss or income loss was an outcome often of COVID, and that is one of the red flags of domestic homicide as well. Significant shifts in mental health for the perpetrator, also present in the time of COVID. And some of the early news reports that came out really did show an increase in the crisis calls or calls to police around domestic homicide and violence in particular. So what we wanted to do was capture this from the ground level. So we partnered with Ending Violence Association of Canada and ran a national survey of service providers across the country who are engaged in gender-based violence. That survey was present or live May to July. We were able to get around 376 responses that came across every province participated and 2 of the 3 territories as well. And so the questions were focused on the impact of COVID on services, the impact on survivors and violence, and the impact on staff in terms of their mental health and well-being. It was well distributed in terms of urban and rural, and it was a good distribution in terms of management versus frontline as well. So what we found, 82% noted an increase in the prevalence and severity of violence. And so when we're starting with a baseline that 1 in 2 Canadian women will experience some form of domestic or sexual violence in the course of her life. And in fact, Stats Canada did an early survey back in April that showed that 1 in 10 Canadian women in that moment in time were concerned about violence in their home during COVID. The fact that there would be an increase from that baseline rate would be really worrisome in terms of prevalence, but in severity, there were things that were being noted in the sense of an increase in particular forms of violence that really get our red flags up. So things like strangulation, things like attempts to end someone's life, that type of thing. 20% notice changes in the tactics used to commit violence. So these are things like using isolation at home as an actual tool. So isolating her from any friends so that she has no sort of out in that environment. Misusing information about the pandemic to exercise control. So bringing home ideas around, you know, if you go and see your friend or if you go and see your mother, you could get COVID and you'll bring that to your children and that will be your fault. So over amplifying risk, talking about sort of you can't go and do any shopping because that's where you will get it, and sort of over amplifying that to increase her isolation. Or even to the point of threatening to bring COVID into the home. So we had heard ideas of, I will go and get COVID and bring that back to you and get that to you and your children. And monitoring and controlling access to technology was another tactic used. So all of us have been much more reliant on technology than ever before to be able to be connected. And when you think about tech as being our one way out of our home at this point, if I don't have the ability, because you're monitoring my phone and even certain particular apps, or you force me to show it to you regularly, I can't call a crisis line. I can't call a friend or a neighbor. I'm even further isolated. 34% also noted changes in the mental health and well-being of survivor, with reports of increases around depression, anxiety, suicidal ideation, and self-harm. And while 34% may not seem drastic, I think it's really important to recognize a baseline here, whereby folks who are experiencing gender-based violence are at significant heightened mental health challenges. So you're already starting there. These are not sort of mentally healthy folks. And so to have that extra burden on is pretty significant. I wanted to pull some of the words because I think they're really powerful. So we've seen an increase in calls to our crisis line, but at the last minute, survivors are changing their minds about accessing the transition house. I think there's fear among survivors of living in this type of communal setting. So when we're thinking about folks trying to balance, do I go into shelter and seek service, but actually communal living probably means I'm at heightened risk of being exposed to COVID, but home is not safe. So no place feels safe at this point. And what a burden that is to try to navigate which sort of risk I want to take on in that moment. I also think it's a bit traumatizing for residents to be faced with really strict isolation and PPE requirements, as strict regulation was often part of the abuse they face and the reason that they came to us in the first place. We've had to make several changes to residents' ability to sign out, isolation upon intake, communal space restrictions, etc., that I feel could trigger past abusive experiences and cause extreme harm to our clients. So a lot of us can sort of note, you know, the necessity of using PPE and isolation. For example, at our shelter, when folks come in, they do have to quarantine for 2 weeks in the shelter, meaning they cannot engage with any other residents. That might seem just intuitive and okay, but what that actually replicates is what your abuser has done. That often will send folks into trigger and to really sort of some harmful behaviors in shelter, which is really problematic, and will sometimes have to be asked to leave, which is challenging. We also know from the literature and best practice that healing cannot happen in isolation. Healing happens in a social context. So with other peers, with a therapist, with really engaging social dynamics. And that's really, really challenging with all of these sort of strictures around communal living in a shelter context. I wanted to focus a little bit on the impact of our staff, because they were one of the front lines and yet were often not recognized as such. So 81% noted an increase in their stress in terms of their workplace. Again, that may not seem astounding. All of us have probably experienced some amount of stress, but these are crisis-based services. So working in a shelter, you'll get a call from a woman. You need to make sure that she has transportation. This may be the only 20 minutes she has to get out of that setting to get her and her children somewhere safe. You may have some sort of really disruptive and violent behavior break out in shelter where you need to call the police that night and do de-escalation in a really physical manner in the shelter. These are really crisis environments. And so to say that 81% already from that baseline had an increase is pretty significant. And so you can see there was also 84% noted health and safety concerns that were increased. And so some of the language around that was COVID-19 restrictions in shelter have meant adjusting our expectations of residents and asking any resident who are unable to follow these to leave shelter. Asking a woman to leave shelter is our worst case scenario. She's already vulnerable. Where is she going to go in that context? So making these decisions, which feel really life and death, are really stressful for folks. And for folks who are doing the work from their home, often therapists doing sexual violence or sexual assault therapy, working for survivors of sexual abuse, you hear a lot of horrible stories every day. Since COVID hit, I had to invite those stories into my home. My entire living space has been slimed with stories of sexual violence, making it hard to leave work at work. I think about work more often. I feel like I can't escape. So I wanted to focus a little bit on where to now. You're all in lots of different capacities, so I wasn't able to sort of pinpoint particular actions for you. But whether that's in your professional role or in your personal role, the reality is you know somebody who's experiencing gender-based violence, or you have known someone who is. Some really key do's and don'ts I thought would be a helpful way to start. So some don'ts. Don't demonize the person committing the abuse. But also don't excuse the behavior. So our gut will often be if someone starts to disclose to us that they're experiencing violence at the hands of their partner, you will want to frame that human as like an awful, awful person, and to kind of align yourself with the person disclosing that to you. But usually what that will lead to is that she will shut down. She will shut down on you because at the end of the day, she still loves that person, and she'll often go into a place of defensiveness for them. So really sort of holding the actions of that person without demonizing them. Don't encourage the person to confront the abuser. That can often escalate the situation. So it's not appropriate to say, well, have you told him that that behavior is really inappropriate and you won't accept that anymore? That type of sort of confrontation in the context of abuse will usually lead to an escalation, which could be really violent. Don't encourage them to leave without a really clear safety plan. I know this is my go-to in terms of my bias and gut. It will be like, well, why don't you just leave? But the reality is that leaving is the most dangerous point in any given relationship. And when we work with a woman or a survivor, we do a ton of safety planning and navigating that moment prior to it happening. So the quick, why don't you just leave, needs to be really thought out and planned for. And the best thing you can do, which is in the do list, is probably connect them to your local crisis and support line for gender-based violence so that they can do that work with them. And so don't push them towards any actions, confronting, leaving, whatever that might be, because that could take a long time for them to be ready. A couple do's. Do ask their partner how they're handling their partner's recommendations. So ask them how their partner is handling the health recommendations. That might give you a bit of an in into sort of where they're at and where the home life is at, where that partner stress is at, what the behavior is like at home. It kind of can open the doorway. Do name what you're seeing. So while you're not pushing them to particular actions, you're not demonizing the person, but you're saying, you know what, you're telling me that he is using really violent language to you, or you're telling me that he's pushing you around. Wow. So name it, don't avoid that naming of it. Use a local crisis and support line, both as sort of a reference for the person, so the woman or the survivor, but also for yourself. You can call that. They will give you tools to help navigate if you've created that relationship with someone around where you can support them next. And do use universally applied trauma-informed care. So if that's sort of unfamiliar space for you, invite someone in to do that training. That's a well-established training area at this point. But you need to expect at this point that everyone would be a survivor of gender-based violence, because statistically, being 1 and 2, prior to COVID, the reality is we aren't going to be able to sort of, in every interaction point, be able to distinguish which one is and which one isn't out of those 1 and 2. So universal application of that will lead you to a best practice of best engagement. We are going to share the slides, so I'm going to sort of not walk through every of these, but sometimes it can be really overwhelming around how to create the open question area in terms of allowing her or the survivor to open up about their experience of gender-based violence, or even to sort of establish whether that's happening if you have that type of relationship with a client. So these are some opening the door questions and some follow-up questions that could be helpful as you navigate those conversation spaces. But thank you. You can see the full report on that national survey on our website, and feel free to reach out if you do have any questions as a follow-up.
Great. Thanks, AnnaLise, for that really informative talk. We'll move to the discussion session. So just as a quick reminder, if you do have any questions, please submit them in the Q&A section, and we'll try to address as many as possible. I'd like to first start out with a question that can be addressed by the entire panel. Clearly, the shadow pandemic is a large problem, but what are the first steps to addressing this problem? Giovanna, you started to talk about some of the ways that health promotion could be more effectively practiced during the pandemic. And AnnaLise, you highlighted some tips for reducing gender-based violence, but what other concrete examples do we have from the pandemic to date? Why don't we start with Vivek? Do you have any thoughts on this? We'll maybe do the same order that we did for the presentation.
And I think Giovanna touched on some of these points in her presentation. The first thing is, I think, is trying to move away from the medicalized sort of approach, which has kind of driven to telling people what they shouldn't do, as opposed to what they can do. And I do want to also be clear that I don't think that the medicalized approach is coming from our public health leadership, because when you look, if you watch the press conferences and announcements of local public health officers from across the health units in Ontario, the provincial, as well as chief public health officers, they do talk about all of these issues, right? But you have to actually watch the whole press conference directly. It very rarely gets picked up by the media as the key message. And the key messages tend to be, again, what are the cases? How do you avoid cases? And then if you look at who the commentators are, they tend to primarily come from the medical infectious disease world. And so, I think Giovanna touched on HIV. I think moving away from here's what you shouldn't do to here's what you can do and how you can do it safely using a harm reduction approach. And so, like, if we think about how can kids play safely together as being the message, as opposed to say, stay 2 meters apart, wear your masks and so on, which has tended to be the message. Pause there.
Great. Giovanna, do you have any thoughts that you'd like to share?
It's a great question, and I don't know that I have much more to add at this point, but it's definitely something that we need to devote more attention to, and yeah, work together to try to find the right approach, I guess.
Yeah, for sure. AnnaLise, do you have anything that you'd like to add?
I think decreasing the isolation for women in particular, so really taking the responsibility of reaching out specifically to those in your networks and sort of making sure that those social contacts are maintained, but also, and sort of the unpopular statement to make, is that if it's 1 in 2 Canadian women, the rate of sort of the men who are also doing this is quite high. It's not the few bad apples, it's widespread. And so if you are a man, sort of acknowledging that you probably know men who are doing this violence and calling them out on it when you start to see really worrying red flags.
Yeah, and just as a follow-up, we know that the risk of stigmatizing certain communities in relation to infectious diseases can be very harmful to those communities. And how can we promote health for ethnic minorities without stigmatizing them? I'll leave this to either one of you if you want to jump in.
Okay, I'll start. I think this is something that I know people in health promotion have been working on for many years. when I first started in public health, there was, again, I think a lot of one size fits all messaging. Here's healthy food, or here's healthy approaches to activity. I think if we don't actually work with the communities, with the community groups on looking at what their, for example, dietary restrictions might be before we put out the messages on what a healthy nutrition looks like, we can wind up with messages that are just not going to resonate or be appropriate for that community. So it is, and those can wind up being stigmatizing. So I think starting to work with the community groups and the organizations that are involved with different communities to develop the right messages for those communities, to me, is the starting point.
Great. Do either one of you have comments on that?
I think I just want to share that, yeah, we do have a lot of experience working with people, with other illnesses and other, issues, right? And so I don't think it changes just because it's COVID-19. I think the approaches are probably the same, focusing on community engagement and community development to really understand how can we work with, communities, especially those who tend to live in vulnerable circumstances, right? So I don't think the approaches really change. It's the focus of the topic that's different at this point. Yeah, so that's just my opinion.
Just very quickly, the bias existed prior to COVID that violence affects particular communities more than others, so that it is classed, it's lower class folks or racialized folks that are violent, not across the spectrum, and that's untrue. The data shows us that across all class and across all races, the rates of domestic violence are roughly the same.
Great, thank you all for that. We'll pivot to another question. Giovanna mentioned how best practices aren't being well documented in real time. You kind of touched on this when you were explaining your last point. But how can we better share emerging best practices for health promotion during the pandemic? Are there certain platforms that exist? What other ideas are there?
I think, there's a lot of organizations and communities of practice that we need to leverage. That tends to be the main way we sort of share information in public health. Probably a lot of them aren't as active right now because everyone is so busy, but really taking the time to protect those communities of practice and sharing the information that way is extremely valuable. Organizations like Health Promotion Ontario, I think that they, by doing these webinars, it's an excellent way to sort of share people's perspectives and approaches and share that sort of work on the ground. So doing more of this is definitely helpful, in my opinion, as well.
Great. Do one more question that can be addressed to the whole panel again. Public health work should perhaps stay locally when driven to identify and address the hidden harms that are cropping up locally. But Vivek also noted the tendency by provincial and federal leadership to use a very medical approach to the pandemic. What could leaders be doing to encourage and facilitate a shift towards more comprehensive approaches to responding to the pandemic? I don't know if Vivek, you'd like to address that first.
And I think, as I said, I think the public health leadership actually has been taking a much broader perspective, but it doesn't get picked up. And I think our political leaders have tended to focus more on COVID as a disease. At one point, the Premier said every case of COVID should be avoided. Recently, I remember seeing one of the teachers union presidents say the same thing, that every case of COVID-19 in schools is a disaster, I think was the word that she used. As opposed to, if you're managing it, detecting it early, and you're creating a safe environment for the pupils, you're actually helping with their development. And so I think it's the challenge for public health is actually, I think, trying to get its voice clearly out there in the midst of all these other voices. And I would say, I think in recent weeks, I've been seeing more direct interventions being made by local medical officers of health and getting into national media. And so perhaps we'll start to see more of that. And I think one of the things that I've been really trying to encourage is people outside of sort of the public health and medical space to get in and comment on things. So on some of the topics that AnnaLise is talking about, we should be hearing from people in social work. We should be hearing from people in early childhood development, from other parts of society around what these impacts are. The media tend to be focused on the daily counts and the impact on cases. And we need to have more stories about all these other impacts. Some of the data that AnnaLise presented should be out there being talked about to the same degree.
Great. AnnaLise or Giovanna, is there anything you'd like to add to that?
We have a really great relationship with our local public health agency, and I just think integrating those across disciplines, as Vivek has said, is key. While you're multidisciplinarians, you're not experts across the field in every area, and so really just reaching out to those that are really close to that work and integrating more and more would be great.
Great. Giovanna, do you have anything to add?
No, I would just echo the comments of them. I think we have the opportunity to build on existing partnerships from people across different sectors and really leverage those to support our populations even better. So I'm sure there's lots of great examples out there already, but we could probably do it better.
Great, thank you. That was a really great discussion from 3 different perspectives. Unfortunately, that's all the time that we have for discussion, but I'm sure our presenters would be more than happy to talk to you about it offline. So we'll just go through our very last slide. We'd like to thank everyone for that insightful discussion. As we come to the end of our second webinar, I'd like to thank our 3 panelists, Vivek, Giovanna, and AnnaLise, for providing insight and next steps as we navigate not only through responding to COVID-19 pandemic, but the shadow pandemic as well. We really appreciate you taking your time out of your very busy schedules to be here with us. Our next webinar will take place next Thursday, November 19th at 12 o'clock, and we will be focusing on how to communicate changing public health agendas during a pandemic. One of my colleagues has entered the link for how you can sign up for that webinar. And just as a reminder, if you're not already, we'd encourage you to follow Health Promotion Ontario on any of our social media platforms, such as Facebook, Twitter, or LinkedIn. And then you'll be able to be up to date on our upcoming webinars, as well as any other opportunities in the future. We would also like for you to stay tuned to an op-ed related to the shadow pandemic, written by HPO executive members Jeanette Leroux and Ben Rempel. The op-ed will feature Giovanna Good, who spoke today, as well as the Medical Officer of Health for Niagara Region, Dr. Mustafa Huri. This op-ed will be featured in the Hamilton Spectator, and the link of this article will be forwarded to all attendees of this webinar. On that note, I'd like to thank you all for being here today and attending, and thank you again to our panelists and the planning committee. We hope that you enjoy the rest of your day and that we'll see you again next Thursday. Thanks, everyone.